Good morning. Welcome. We'll continue the biochemistry of cancer. And as the incidence of cancer is increasingly disturbing the health of the people nowadays, it is our responsibility to basically know what is the biochemical underlying cause for the development of cancer. So, you know pretty well that categories of DNA modifications. Last time we came up here. The types of genes involved in cancer are oncogenes, tumor suppressor genes, and stability genes. So, oncogenes. So, these are the genes capable of causing cancer. Michael Bishop and Harold Warnes, they are pioneers in the oncogenic research, and they were awarded Nobel Prize in 1989. Michael Bishop, Nobel Prize in 1989, he was born in 36. Harold Warnes, Nobel Prize in 1999, he was born in 39. Just both of them are just 3 years born apart. So cancer causing agents, they affect the normal cell and they create a proto-oncogene. And then the activated oncogene will come out of the DNA, and that will involve the cell and create cancer cell. So oncogenic viruses are, they contain either DNA or RNA as the genome. Integration of viral genes into the host DNA overrules the regulatory checks. There are so many checks, but once the viral genes are integrated into the host DNA, there will be overruling. No checks, no balances, nothing. So transformation will take place. Suppose a fellow marries the commissioner of police daughter, as in cinemas, modern cinemas. He doesn't have any rules. All the fellows will make a schedule to him and say that he is the son-in-law of the commissioner of police. That will go. That's all. So there will be no checks. Regulatory checks will not be working on that. And once viral genes are integrated to the host DNA, all the regulatory genes are lost, and the balancing mechanism, lots of balancing mechanisms are existing in the cellular mechanism. So all the things are lost once the viral gene enters the host DNA. So we have a little bit of information on that. Epstein-Barr virus, that is abbreviated as EBV. Wherever you see EBV, you have to take it for granted that Epstein-Barr virus is being mentioned. So with that, the associated cancers are Burkitt's lymphoma, nasopharyngeal carcinoma. You know, Burkitt's lymphoma and the nasopharyngeal carcinoma mostly affects the nose and the larynx. The next one is human papillomavirus. You know pretty well about human papillomavirus. Just warts like that they will appear, and that mostly comes through the husband. So husband sexual intercourse will introduce the human papillomavirus into the vaginal cavity. From there it will enter the cervical upper cervix, and then they will cause so much of papillomavirus. So that cervical cancer will result at night, and sometimes uterine cancers. So human papillomavirus is the most dreaded donation from the husband to the wife. If one is careful and healthy, this problem can be elevated. That's why Mohammedans will observe Sunti. Sunti is nothing but taking away the foreskin on the glans penis. So there will not be any collection of smegma underlying the foreskin. So that problem is totally avoided, and whenever he undertakes intercourse with the wife, there is no problem for the wife to be exposed to the smegma or any of the human papillomavirus. So he will always keep fresh and healthy. His genital health is up to the mark. You can take it for granted. So that's why they know pretty well how to prevent uterine and cervical cancers by making it religious circumcision. So all the people who are Mormons, they should undergo, the males should undergo circumcision at the age of just 1 or 2 years. That's all. They do not know what is happening. They just take him and keep him a red glue around the waist and give him 1 or 2 chocolates and make him sit on a hard surface. And they just stretch the foreskin and one blow will cut the foreskin. That's all. And the baby will scream and they'll give 2 3 chocolates. That's all. There ends the religious circumcision. But once it becomes an elderly man, it takes a lot of trouble for him. We do it as a surgical circumcision in the hospital setup. That also is not a problem. Under local anesthesia, we do it. We apply around the whole skin 6 or 7 stitches, and we need not remove it. Slowly they will wear and tear off, and after a period of 15 days, everything will be normal. So third thing is hepatitis B virus, HBV. You know pretty well about this, and most of the times our Gayatri Vidya Parishad is giving free of cost hepatitis vaccine. So hepatitis B virus is a dreaded one that can spread through just touch, semen, serum, through everything. It will easily spread. So that easy spread can be arrested by taking hepatitis B vaccine, three doses at 1 month intervals at least. Doesn't matter. It should be done in every 21 days, but even for 1 month interval also, it's not a problem. Just one dose will cost about 40 to 60 rupees if you want to get it for yourself separately. And if you buy 5 ml wires, even 10 people can share it happily. So hepatitis B virus, if it enters the blood, will be declared as hepatitis B positive. If once he is hepatitis B positive, there is no procedure by which we can declare the man as hepatitis B negative. So nothing will happen to him. He will be like all of us. But only thing is, hepatoma, liver cancer will be waiting for him. Primary hepatic cell carcinoma. That is the thing that will ultimately end up his life, where nobody can take up any remedial measure, no liver transplantation, no sort of any activities can help this patient. So remember, all these things are vaccine preventable. The human papilloma virus can be given, all the people can be given, unmarried people can be given just before 60 years this vaccine, and when they go into marriage and have sexual intercourse, nothing will happen for them. For uterine cancer, the cervical cancer. So science is advanced so much. Only thing, the fruits of science should be exploited by all of us, and we all should accept the scientific research. So Renato Delbecco, he got the Nobel Prize in 1975, was born in 1914. The transfer of viral genes to the cell is mediated through an enzyme. But remember this name, called reverse transcriptase. If you wanted to spell precisely, RNA dependent DNA polymerase. And nowadays it's better. Remember it as precisely as possible. So we call it as reverse transcriptase. More precisely, RNA dependent DNA polymerase. So this replicates the viral genome made up of RNA into DNA, and later it is incorporated into the host genome. So viral DNA and viral DNA attaches to the host DNA, and one strand will be transferred, and DNA repair and virus integration will take place into the host DNA variants. That's all. So viruses promoting human cancer. So they include both DNA viruses and retroviruses and some types of RNA viruses. Remember, if we ask this question in Viva, you should be able to definitely recollect these three things. So viruses promoting human cancer include DNA viruses, retroviruses, and type of RNA viruses. So Epstein-Barr virus, they cause Burkitt's lymphoma. Human papillomavirus, they cause cervical cancer. Hepatitis B virus, they cause liver cancer. Human T-cell lymphotropic virus cause adult T-cell leukemia. Kaposi sarcoma associated herpes virus causes Kaposi sarcoma. Most of the people suffering with hepatitis 1 and 2 ultimately develop the herpes disease, and they will be exposed to Kaposi sarcoma. So this is mostly affecting the lung. In 1910, Peyton Bruce, in good olden days with a small available microscope, he found the first retrovirus in chickens' filtered sarcoma. The chicken used to have a big sac-like growth affecting the neck region, and that was quite common. Nothing happens to the chick. So he used to dissect carefully that sac, and he used to triturate it with silica, sterile silica, and he used to filter it and ultrafilter it, and he used to inject it into healthy chicken at various places of the body. So he researched whether any of the chickens grown in his farm will be developing the sarcoma. So he found the first retrovirus in chickens' filtered sarcoma. Bruce got the Nobel Prize in Physiology and Medicine in 1966. After 50 years, he was almost forgotten. His life and activities and achievements were almost forgotten by the people. But finally, one of the young men again reactivated his research and brought life to his research. So DNA tumor viruses, the viruses can contribute to cancer by inserting their DNA into chromosome in the host cell. Insertion of the virus DNA directly into the proto-oncogene may mutate the gene into an oncogene. You have to remember it very clearly, resulting in a tumor cell. So, chemical carcinogens. We have pro-carcinogen, that is proximate carcinogen, or ultimate carcinogen. Pro-carcinogen leads to proximate carcinogen, that leads to ultimate carcinogen. They bind covalently to macromolecules inside the cell like RNA, DNA, and proteins. Carcinogens are electrophiles that shrink in electrons. So when the electron deficiency is there in the outer structure, they will attract anything and everybody. So they will readily attack nucleophilic groups of DNA. So there are 5 mechanisms. The proto-oncogenes are activated to oncogenes by various mechanisms, and the 5 mechanisms are described. Promoter insertion, enhancer insertion, chromosomal translocation, gene amplification, and point mutation. These are the 5 mechanisms by which proto-oncogenes are activated to oncogenes. You have to just remember it while they are facing the Bible. So initiation and promotion. So for example, initiate is a benzopyrin. If you apply it on the skin, nothing will happen. No tumor will result to the human being. So we add the initiator benzopyrin, and after some days we add the promoter protonine. Then after some days we wait, we will develop the tumor. And there is another way. And the promoter protonine will be applied on the skin repeatedly, and then the initiator benzopyrin will be applied. No tumor will be there. So these are the 3 simple research procedures they follow, and how the tumor growth takes place, they came to the common understanding. So variety of compounds like phenobarbital and saccharin can act as promoters. The active agent of protonine is a mixture of 4-ball esters. We call it as 4-ball ester. So now, second one, enhanced insertion. Insertion of a viral cDNA downstream of the oncogene is known as enhanced insertion. So Mike is there, it will be inactive. Make acts as a DNA binding protein and offers gene expression. And the provirus should sit there, and then only make mRNA will be synthesized. Then gene translocation, reciprocal translocation in Burkitt's lymphoma. Translocation is from short arm of chromosome 8 to short arm of chromosome 14. And in reverse process, translocation occurs from short arm of chromosome 14 to chromosome 18. And this is giving some small weight. It also donates some small weight. So this is reverse process of translocation. So translocated piece from chromosome 8 contains Mike gene that is placed next to the gene transcribing each chain of immunoglobulin, and then it will become activated. Then gene amplification. Amplification of genes causing increased expression into many folds. Amplification of certain genes are found in some tumors. It can be induced by certain anti-cancer drugs also. So that causes drug resistance, like treatment with methotrexate. So methotrexate is known to be acting as a good anti-cancer agent, but sometimes if you prolongedly use it, it will cause resistance. So point mutation. Point mutation is observed in some cancers. So CRAS P21 GT-place activity and diminishes the activity of adenyl cyclase. And the same CRAS P21 mutation at 12th position causes loss of GT-place activity and overstimulation of adenyl cyclase will take place. So this is the simple diagrammatic representation. Proto-oncogene near the DNA, then point mutation with the gene resulting in opposite. Normal amount of hyperactive protein will lead to the point mutation. And proto-oncogene, multiple pieces of gene and excessive amount of normal protein and DNA amplification. And proto-oncogene moves from normal location to a different location on another chromosome. A new location could activate and convert the gene, resulting in excessive amount of normal protein leading to translocation. So these are all the words that you should be more conversant by repeatedly studying and repeatedly writing down on your notebook. Then polypeptide growth factors. This is the most important one. Most of the times you will get it as a short notes in the examination. Polypeptide growth factors are mitogenic. Growth factors are polypeptide substances secreted from different cells and they cause mitosis. Growth factors may be endocrine growth factors, paracrine growth factors, autocrine growth factors. So they act on mitosis via the transmembrane signal transduction, that is the root transduction. So there are a set of growth factors. EGF, the source is most cellularly gland. Function is stimulates growth of many of the epidermal and epithelial cells. Erythropoietin, pretty well, for the body to synthesize RBC from the bone marrow, we need erythropoietin from the kidney. Kidney synthesizes erythropoietin, and as long as the kidney is actively working, a lot of erythropoietin, sufficient amount of erythropoietin should be secreted. And if that is there in sufficient amounts, you don't have any problem. But once the fellow is landing up into uncontrolled diabetes mellitus over a long period of 20 to 30 years, not 1 or 2 days, nothing will happen. So all the diabetic people are just living, and the most of that nothing is happening to me, even though you say 100 things about this. But it's not true. They should be aware of this problem. So as long as the kidney is functioning happily, nothing will happen to the diabetic fellow in spite of his bad or worst control. Because once it surrenders and enters the kidney failure, renal failure, slowly the erythropoietin production will be less and less. And once it is less, the production of RBC from the bone marrow will be linger. So then slowly you will end up in kidney failure, bleeding. Then you should go for transfusion, so dialysis. So third thing is IGF-1 and IGF-2. So the source of IGF-1 and 2 are from the serum. So function is sulfate incorporation into cartilage. That is the most important one. And nitrogenic for chondrocytes. And exert insulin-like effects on many cells. So third thing is transforming growth factor A. So that is derived from tumor cells and placenta. So this the function is similar to EGF. So simulates the growth of many epidermal and epithelial cells. And TGF-B, the source is placenta and platelets. So they inhibit fibroblasts. Platelet-derived growth factor is derived from platelets and they accelerate wound healing. That's why they are collecting the platelet healing and they are slowly infiltrating in a chronic ulcer area and it achieves miraculous wound healing, which was not possible even though they have gone repeated skin transplantation. All these things will be failing and rejected. But ultimately, the platelet-derived growth factor acts into accelerated wound healing. And for that, you should have definitely the basic information about the placenta. From the placenta, we will collect all the cells. That is possible nowadays. So, nerve growth factor is another thing. Submaxillary gland. So, submaxillary gland gives growth of sensory neurons. So, familiar human growth factors, EGF, submaxillary gland, kidney, duodenal gland, and EPO of kidney, HGF, placenta, IFN, gamma, activated TH1 and Ganglion cells, IGF, placenta, primarily liver and plasma, NGF, neurons and submaxillary glands, 2EGF, platelets and endothelial cells and placenta, TGF alpha, tumor cell and transforming cell placenta, TGF beta, activated TH1 cells, T helper cells, and natural killer cells, VEGF, smooth muscle tumor. So, mechanism of action of growth factors. So, they will bind to the membrane receptor and then tyrosine kinase activation will take place and that will lead to the intracellular related protein phosphorylation and then it will lead to the intranuclear transcription of factor activation and finally genetic transcription takes place. That is one way. Second way is the binding to the membrane of receptor producing second binding. And then concerned protein kinase will be activated that will go into the intracellular related protein phosphorylation and that will go into intranuclear transcription factor activation and finally genetic transcription. And the other way is binding intracellular receptor that will lead to the growth factor the receptor compounds activation related gene and that will go into genetic transcription. These are the three roots interlinked with each other. So, tumor suppressor genes, this is most important, you should try to remember these things. So, genes which prevent the causation of cancer is known as tumor suppressor genes. So, these are sometimes called as recessive oncogenes or anti-oncogenes. So, oncogenes, mutation in one of the alleles is just sufficient to become an oncogene, but to become tumor suppressor gene, mutation in both the alleles is required. So, for oncogenes, gain of function of a protein that signals cell division is just sufficient. The suppressor gene, loss of some function of a protein is most important. And for oncogenes, mutation in somatic cells, which is not inherited. Mutation in germ cells, which is inherited. The germ cells are at risk. So they finally come to the surface. So for oncogenes, some tissue preference is existing. But tumor suppressor genes, strong tissue preference, only one type of tissue can be affected. So tumor suppressor gene is known as anti-oncogene. It is defined as a gene whose protein products inhibit cell division, thereby preventing uncontrolled cell division. So tumor suppressor gene is anti-oncogene. It's a gene whose protein products inhibit the cell division and thereby preventing uncontrolled cell growth. So cancer will be prevented. That's known as anti-oncogene. So these are all the, just like brake pedals. Tumor suppressor genes act like a brake pedal. So growth factor will attach the receptor. There itself, first tumor suppressor genes will inhibit the attachment of growth factor to the receptor. And then signaling enzymes, once it enters the cell, signaling enzymes should start getting produced. And that will be inhibited by tumor suppressor gene proteins. And then once it enters into the nucleus, transcription factors will be released. And that also can be stopped by the transcription factor DNA can be, synthesis of transcription factor DNA can be arrested. And ultimately, if all the things go without inhibition, cell proliferation will take place. So at every stage, God never allows us to develop into cancer patient. At all stages, there is a check. And it will be given to the blessed people who believe in the science and whatever they say, God. The retinoblastoma gene, RB means retinoblastoma, abbreviated as RB. Major function of RB gene is the regulation of cell cycle procession. You know the cell cycle. So mechanism, G0, G1 phase, RB protein, E to F, and then DNA. In S phase, RB protein and P, E to F, DNA and synthesis of mRNA. So hereditary retinoblastoma, somatic retinal cell, and somatic mutation, homozygous cell gives rise to tumors in retina. So without that, sporadic retinoblastoma also is known. Even without heredity factor, there is sporadic retinoblastoma. So somatic cell, retinal cell will be there. And first somatic mutation will take place. And in the second somatic mutation, homozygous cell gives rise to tumors in the retina. So it's all quite unfortunate. So P53 gene, P53 protein towards the acidic region, and centrally the core region will be existing, and then basic region will be on the other side. P53 gene encodes the protein with molecular weight 53 kilodaltons. That's why it's named the P53 protein. Some of the genes are, some of the proteins are named basically on the molecular weight, coding the restrained protein relating to cell cycle control. When tumor suppressive gene is deleted and mutated, there is a induced occurrence of tumors. RP gene and P53 gene, you have to remember. Then biological functions of P53 protein. It will suppress the cell cycle, it will suppress the transformation function of some oncogenes, it will monitor the cell DNA damage, and will induce the cell apoptosis, cell death. So metastasis, neoplastic cell, cancer cell, it will undergo degradation of basement membrane, and it will be interact with the extracellular membrane and degradation of extracellular membrane and invasion of blood vessels. And each of the steps, neoplastic cell will release growth factors and lead to angiogenesis, new blood vessel growth, and then collagenesis. The collagen will be disrupted, and more of the spread in the beyond. The interaction with ECM will lead to the again growth factors, angiogenesis, and collagenesis. And all said and done, neoplastic cell can directly jump into angiogenesis and directly invade the blood vessels. That is the way by which the cancer mostly spreads fastly. So mutation inactivates tumor suppressor gene and cells proliferate. One cell will become 16 cells. And mutation inactivates DNA repair gene also. The mutation of proto-oncogene creates an oncogene. And mutation inactivates several of the more tumor suppressor genes and they end up in cancer. So cells are born and live for a given period of time and then they should die. Nobody can just live on the face of the earth as a immortal man. They should end up their life after 60 years, 70 years, 80 years, 90 years, 100 years. And some of the people are there, in Japan and China, more than 100 years, 120 years, we are seeing in the newspapers. So cells are born and live for a given period of time, maybe extended period of time, and then they should die one day or another. So it is known as apoptosis. That's otherwise known as physiological cell death, or in a more harsh words, cell suicide, and in more palatable words, cell deletion. Ultimately, scientific word is programmed cell death. So apoptosis is programmed cell death. Everything is programmed. Removal of superfluous, aged or partially damaged cell is done by apoptosis. So the term means dropping off, similar to the old leaves falling from the tree. So nucleus shrinkage, chromatin condensation, membrane blebbing, and stepladder pattern of DNA and electrophoresis, they are characteristic features of apoptosis. So we can document all these things. So nuclear shrinkage will take place, chromatin condensation will take place, membrane blebbing will take place, and stepladder pattern of DNA and electrophoresis will be noticed. So these are all the characteristic features of apoptosis. Apoptosis mediating genes are otherwise known as suicidal genes or oncosuppressor genes. To name it in a better way, oncosuppressor genes. They are CFOS, P53, and R. Apoptosis protecting genes are BCL2 and some oncogenes. Stress and other stimuli activate certain cell surface receptors, and a cascade of activation takes place. The final effector mechanism of cell death is through the activation of capsaicin. Remember this word. So the final effector mechanism of cell death is through activation of capsaicin. So difference between apoptosis and necrosis. So normal cell, we know pretty well about the representation. And then the chromatin nuclear collapse will take place, and then membrane blebbing will be taking place, irregularity of the membrane, resulting in blebbings. And cell contents are repacked. The blebs, small molecules and fragments of cell will be entering. And then cell will die. That is apoptosis. And the same thing will happen in necrosis. Normal cell will start exposed to normal wear and tear, and the proteins will break down. Osmotic pressure causes cell swelling, and that will lead to cell necrosis and cell lysis. So differences between apoptosis and necrosis are depicted simply by this. So general features of apoptosis. So number of activities take place: occupation of death receptors, dimerization of BCL2 family members, release of cytochrome C, activation of capsaicin, and activation of DNases. Oncofetal antigens. Oncofetal antigens. During the fetal life, a particular gene is active and they produce a protein, and they will produce inside the cell. during the differentiation process as it is going on, and the gene is suppressed, and so the protein is not present in the adult cells. However, along with the malignant transformation, the de-differentiation occurs and the gene is de-repressed and the protein is again available in the cell. So such products are classified as oncofetal proteins. An example for that is alpha-fetal protein AFP. In hepatomas, they will be still present even in the adult life. So if we happen to see AFP, then we are sure that the fellow is going to suffer with hepatomas. Carcinoembryonic antigen CEA. If it is present in the blood sample collected by a middle-aged or over 60 years of individual, so it represents that he is going to get colon cancers, colonic cancers, transverse colon cancers, descending colon cancers, all types of cancers related to the colon will be there. So they generally serve as tumor markers. Most of the times we are sure that they are going to develop this. So embryonic antigens will be expressed in the embryonic cells like that. The functional gene is inside and the embryonic cell will be expressing the embryonic antigens. So when the normal adult cell forms, the antigens are not expressed and a particular gene that was present in the embryonic cell will be repressed. And in malignant cell, again gene de-repression will take place and again it will be surviving and it will be slowly going to give embryonal antigen re-expressed, that is tumor antigen. And oncofetal antigens lead to the malignant cell transformation. So they are overexpressed by malignant cells. They are usually normal cellular constituents that are present in normal or very low levels in the blood of healthy persons. But they are called tumor index substances. They are factors released from the tumor cells which will be detected in the blood and therefore indicate the presence of tumor in the body. So applications of cancer biomarkers. So we can just collect the blood and screen it, and we can find out what type of cancer this fellow may develop, may suffer in the forthcoming years. So that is tumor screening. And suppose we have given some type of drug. So based on the screening, certain of the biomarkers will suggest development of a particular cancer, and we know what type of chemotherapeutic drug should be given. So selective approach. So therapeutic targets can be selected. And when once we started the treatment, how the fellow is responding to the therapeutics and how he is progressing, how he is developing normal life. And these are all the things that are the benefits. And risk assessment and monitoring progression are the two other things. And then once we find out the thing, we know differential diagnosis between 4 or 5 types of cancer, what type of cancer is going to develop. So when they are useful for screening, they are useful for early detection, they are useful for diagnosis, they are useful for monitoring. So types of biomarkers, these biomarkers are interrelated and beneficial one on the other thing, so it is enforcing one on other things. So prognostic value to treat or not to treat. And pharmacodynamic activity, what dosage should be given, what type of treatment, prediction, what type of treatment should be given, and diagnostic, what type of disease it means that fellow is suffering. So a characteristic that is objectively measured and evaluated as an indicator of normal biological process, pathogenic process, or pharmacological response to a therapeutic intervention. A naturally occurring molecule, gene, or characteristic by which a particular pathologic process, disease, etc., can be identified. A biomarker is a measurable indicator of the severity or presence of some disease state. A biomarker is anything that can be used as an indicator of a particular disease state. Then tumor marker classifications. They are classified into various groups: enzymes, hormones, proteins, oncofetal antigens, genes, carbohydrate antigens, blood group antigens, and receptors. So tumor markers, the breast cancer, CA125 and CEA are the markers. And for liver cancer, AFP. For pancreatic cancer, CA125 and CEA. In ovarian cancer, CA125 and CEA. And for lung cancer, CA125 and CEA. You observe some of the tumor markers. I will give an idea that he may develop this or that cancer. It is up to us to wait and see and find out the development. And stomach cancer is given by CEA. Colonic cancer is given by CEA. And prostate cancer, prostate-specific antigen. In good old days, we used to have acid phosphatase, just like alkaline phosphatase for vitamin D deficiency and bone cancer. We have acid phosphatase, and this acid phosphatase, we used to observe that it will be increasing in the states of prostatic cancer. And prostatic cancer, most of the people who are above 60, 70 years, only men, because prostate is not present in the women. So the one thing that is happy about women is they don't get the prostate cancer because they don't have prostate. The prostate gland is present only in 50% of the population. Those are the male people, and that too beyond 60 years. So when it is slowly enlarging, the central lobe and two lateral lobes, any of the lobes is slowly enlarging, and if they transform into cancer, then the prostate-specific antigen titers will slowly rise. If they are more than 4 or 4.5 like that, we have to keep an eye on the prostate, and we have asked them to come as frequently as possible, if you can afford, once in 3 months or once in a year. And every time when once he comes, one thing that will not involve much of the fees and investigation trouble, financial trouble, is a finger glove we can put on to our finger, and we can ask them to stay in whatever position, or hold position or without position. We can introduce it into the rectum, and we can slowly palpate the surface of the prostate gland. And if it is irregular, then mostly it can be prostate cancer. If it is regularly enlarged, okay, we can take it for granted that it's a benign prostatic hypertrophy up to some extent. All said and done, the enlargement of prostate will unnecessarily interfere with the bladder neck. And this bladder neck, when it gets straight, there will be stress incontinence. And the fellow, when he is stressed, he will pass the urine inside his pants, or he has to run without caring for anybody that comes in the way to empty his bladder. And prostate cancer, the prostatic enlargement, that may go into adjunct continence, stress incontinence. Adjunct continence means once if it is full, he cannot retain the urine. While walking to the bathroom, the urine will be dribbling. So these are all the problems with the men after 60, 70 years, suffering with the benign prostatic enlargement and prostate cancer. And testicular cancer is another one that will be treated by AFP and HCG. So common tumor markers are oncofetal products, alpha fetoprotein, AFP. Serum levels are increased in lymphoma and germ cell cancers. Also, embryonic antigen CEA will be increased. The serum levels will be there in colorectal cancers gastrointestinal cancers, and lung cancers. So oncosurgeons and the oncotherapeutic doctors, they will be knowing great length of this, and we cannot just ask them to tell all these things when some of our close relatives address their Asian Institute of Gastroenterology in Hyderabad, or some great gastroenterology clinics in Bangalore. We cannot ask them to just spend time to teach us. They just laugh and say that we are not free, and it's better for you to go to the books. They cannot just sit with us and tell it in a broad way, operated way. So just they laugh and simply say that we have not read, we have not learned these things when we are students. So that should not come to any of our life. So we should be knowing a little bit about everything as a student. And then as a PG, you will be knowing most of the details. Once you become a medical radio diagnostician, MD, or oncosurgeon, surgical oncologist, you will be knowing most of the details. So oncofiltered proteins, and then carbohydrate antigens are CA125. That is, ovarian cancers of epithelial organ will be expressing CA125. And the tissue antigens, they don't have any specificity. And tissue polypeptide antigen, general cancer load will be detected. And then enzymes, alkaline phosphatase, bone secondaries, placental type of ALP, they will be depicting the lung metastasis and seminomas. Prostatic acid phosphatase, prostate cancer. Prostate specific antigen, prostate cancer. Neuron specific imolase, nervous system tumors. So these are all the specific things. When we know this, we can just go and discuss with our oncotherapy or oncosurgeon. So common tumor markers, hormones and their metabolites. Beta HCG. You know alpha HCG and beta HCG. Alpha is present with all the things in pregnancy and everything. Beta HCG is specific for choriocarcinoma. You know pretty well. The choriocarcinoma will be from the grape-like proliferation of the cells, and finally the entire uterine cavity will be occupied by the grape-like growth, and there will be no fetal parts. And for the period of amenorrhea, say the mother will say that we got married 4 months back. But when once we palpate the height of the uterus, we feel like telling, but we don't tell it. Amma is always showing that she is more than 7 months old. We should not do that. Because it may be simply choriocarcinoma. So these things should be known by ultrasound scan. And if no fetal parts are present, then we will mention that. Otherwise, unnecessarily mentioned it will raise up the doubts in mother-in-law's mind. And then calcitonin, medullary thyroid carcinoma, ACTH, lung port cell cancer, IED carcinoma, vasoactive intestinal polypeptide, adenomas, amine precursors uptake the decarboxylation. That's why adenomas. Vanillyl mandelic acid, pheochromocytoma. So the cap of the kidney will be producing large amounts of adrenaline and noradrenaline, and it will be formed into vanillyl mandelic acid. 100%. Okay. Hydroxyindorestic acid, carcinoid syndrome. Tissue catabolic products, hydroxyproline. So serum proteins, immunoglobulins, IgG, multiple myeloma and macroglobulinemia. And Jones proteins in urine, multiple myeloma. Receptor tumor markers are estrogen receptor and progesterone receptor tumors in carcinoma of breast and carcinoma of uterus. And ACR2 neuro and ERB2, EGFR2 carcinoma of breast. So, monoclonal antibodies used as anti-cancer agents are rituximab is targeted for CD20 and B cells. They use against NHL and CLL and B cell leukemias. And trastuzumab, capacity. So they will be targeted for HAR2, neuro, and EGFR2, ERB2 breast cancers. And bevacizumab, EGF, colorectal cancers, and solid tumors of kidney and breast. And etemtuzumab, CDF2 on B cells and CLL. And cetuximab is the anti-cancer drug that is used for KRAS and colorectal and head and neck or pancreas. And the panitumumab, EGFR, colorectal cancer, imatinib, tyrosine kinase, CMI. So non-Hodgkin lymphoma and colonic lymphoid leukemias and choroid myeloid leukemias and epithelial growth factor receptors and vascular endothelial growth factors are all targeted by these various types of tumors, chemotherapy drugs. So, tumor marker concentrations will fastly come down to baseline, cuff level, when the response is very good. When there is no response, it will be going into platosis. Then slowly after some time, after months or weeks, if it comes back to high levels, we can say that it is in a relapse stage and no treatment is advised. When second remission takes place, there is no. So hepatocellular carcinoma is present in alpha fetoprotein. Normal levels are less than 10 nanograms per ml. AFP is evident in acute and chronic hepatitis, but it seldom gets above 100 nanograms per ml. AFP levels are over 4,000 nanograms per ml in liver cancer. So cholangiocarcinoma, concentration and follow-up, and recurrence when it slowly rises after months of treatment. So carcinoembryonic antigen, colorectal cancer, the normal range of blood levels is 3 nanograms. The higher the CEA levels, more likely that the cancer is advanced. So carbohydrate antigen CA125 is a glycoprotein with molecular weight 10 millions. Normal level is less than 35 units per ml. It's elevated in ovarian cancer, pancreatic cancer, GI tract cancers. And CA124 normal blood level is 35 units per ml. More than 90% of women have high levels of CA125 when the cancer is advanced. Neuroendocrine tumors like small cell lung cancer, neuroblastoma, and carcinoid tumors presenting with neuron-specific enolase (NSE). Normal levels are usually higher than 9 picograms per ml. And PSA, prostate-specific antigen, is a glycoprotein, ideal as a tumor marker, high tissue specificity, high sensitivity for prostate cancer, elevated in benign prostate hypertrophy and prostatitis also, but not so aggressive. Useful for differential diagnosis, follow-up of prostate cancer, and prognostic factor to monitor recurrence and response to treatment for screening of prostate cancer along with other things. Breast tumor samples for estrogen and progesterone receptors, you should not take any blood samples. So about 2 out of 3 breast cancers are positive for one of these markers. Cancers that have these receptors can be treated with hormone therapy like tamoxifen. So it's a Z. It's a growth factor that tells breast cancer cells are growing. Testing a sample of the cancer tissue itself is most important. No help from the analyzing blood sample. About 1 in 5 breast cancers are positive. And these cancers tend to grow and spread more aggressively than other breast cancers. All newly diagnosed breast cancers should be tested for HAR2. HAR2 positive cancers will respond to trastuzumab, that's known as Herceptin drug in the market, and lepatinib in the market is marketed as Ticagrelor. And that works against HAR2 receptor of breast cancer cells. The first tumor marker reported was Benz-Jones protein in multiple myeloma in 1847. This is most commonly seen in most of the men and women beyond 60 years of age. But nowadays we are getting cases even after just 40 to 50 years of age. They will become very thin and emaciated. They will develop high fever. You don't get any interest to eat anything. And slowly, when we take the total body um, scan, then we will find a lot of secondaries by the time we go for scan. So healthy bone marrow will be like that. The person suffering with multiple myeloma will have the cancer growth like that. So the antigens, white blood cells, B cells, and the plasma cells, normal antibodies. But here, once the DNA is damaged by multiple myeloma, the damaged white blood cells, B cells, will enlarge and multiply multiple myeloma cells. They release the M proteins, myeloma proteins. One reason that cancer cells have increased life is persistent activity of telomerase. So the enzyme maintains the length of the telomeres and region of the chromosomes. So tumor kinetics, cell cycle is divided into G1 as G2 phases. Cell cycle being completed within 18 to 24 hours. Cell cycle time is more or less same for the normal and cancer cells. In a normal tissue, only 1% cells are in the dividing stage. In cancer cells, 2 to 5% of the cells are in the cell cycle. And this number demarcates a mildly growing tumor 2% from an aggressive one 5%. This difference is made use of for the treatment. Cytotoxic drugs and radiation will kill the cells in the cell cycle by sparing the resting cells. So standard cancer treatment, surgery, removal of cancer cells, radiotherapy, destruction of cancer cells using radioactive rays, and chemotherapy, killing the cancer cells using the drugs. So surgery and radiotherapy are most effective to reduce the initial tumor cells. These are the prime modalities of treatment in solid tumors. Chemotherapy is the sheet anchor of therapy in leukemias, lymphomas, chorioplastomas, and other widely disseminated malignancies. The differences between cytotoxic drugs is directly proportional to the doubling time of the tumor and is inversely proportional to the number of cancer cells. Cytotoxic drugs affect all the cells which are in the dividing phase. The rapidly dividing normal cells like gastrointestinal tract, hematopoietic system, and hair follicles and gonads, they are also affected by chemotherapeutic drugs leading to toxicity. So the structural alterations in methotrexate will convert it as a very good folic acid inhibitor acting as a best cancer drug. So methotrexate, folic acid analog, competitive inhibitor of dihydrofolate reductase, and dihydrofolate reductase is required for the nucleotide synthesis. And 6-mercaptopurine is a purine analog, inhibits the conversion of IMP to AMP. And 6-thioguanine is a purine analog, inhibits the synthesis of purine nucleotides. 5-fluorouracil is the pyrimidine analog, inhibits thymidylate synthase. And cyclophosphamide is an alkylating agent, cross-linking of bases of DNA and inhibition of strand separation. Mitomycin C is an antibiotic, and cross bridges are found between DNA and base pairs. Actinomycin D is an antibiotic. It intercalates with the guanosine bases of the DNA and prevents transcription. Vincristine and vinblastine from plants, alcohol from Vinca rosea group of plants, interferes with the assembly of cytoskeleton, inhibits staphylokinesis, spindle movement. So adriamycin, anthracyclines, so topoisomerase mediated breaks in DNA. Etoposide, podophyllin toxin, stabilizes the topoisomerase 2 and DNA cleavage complexes. Cisplatin, platinum compound, forms intrastrand DNA adducts. Imatinib, it monoclonal antibody type, tyrosine kinase inhibitor. Sorafenib, it's a monoclonal antibody targeted kinase inhibitor and used for renal cell cancer.